Welcome everyone. We'll talk today about fluid and electrolyte in MRCS point of view. We will focus on fluid and electrolyte. In the fluid we will talk about normal distribution of the fluid, movement of the fluid across capillary, crystalloid versus colloid, and burn fluids resuscitation. And we'll talk in electrolyte in potassium and sodium. The fluid composition and distribution. You know, it's a difference between male and female that the percentage of total body weight that fluid can present in the body is 60% in the male adult and 50% in the female, because in the female it contains more fat. The distribution of this 60%, the rule of 60-40-20 rule. That means the 60% of the total body weight, it's about 40% intracellular fluid and 20% of extracellular fluid. The extracellular fluid, the 20%, is also divided into plasma 5% and interstitial fluid in 15%. The movement of the fluid across these compartments, it depends on four forces. The capillary hydrostatic pressures, that moving the fluids from the capillary to interstitium, counteract by interstitial fluid hydrostatic pressure, and also there is the osmotic force due to plasma protein concentration, that tendency to reabsorb the fluid from interstitium back to the capillary, counteract by osmotic force due to interstitial fluid protein concentration. The net results will be the force, that tendency towards the capillary, it's more in the lateral side, in the venous side, and in the arterial side of the capillary. The net forces will be for moving the fluid from the capillary back to interstitium. We'll go for another session, will be the crystalloid versus colloid. There are two main of intravenous fluid, two main types, crystalloid and colloids. Crystalloid are aqueous solution of mineral salts or other water soluble molecules. The most important one is 0.9% saline, normal saline, Hartmann's, and dextrose 5%. Colloid also contains large insoluble molecules such as gelatin, and blood itself is a colloid. The most important information you have to know is that using of ringer lactate or Hartmann's is when the crystalloid is needed for resuscitation or replacement of fluid due to its balanced electrolyte content like plasma. So in every situation you need a resuscitation or replacement of the fluid, use the rich and balanced electrolyte content solution, which is Hartmann's or ringer lactate. On the other hand, the normal saline will be used only when a patient is vomiting or loss of gastric acid due to risk in hyperkalemia acidosis in other situations. So the normal saline is for patient vomiting or losing his gastric acid. We will need a normal saline. Otherwise, we will use the best one, with the best solution rich in electrolyte, which is Hartmann's. This will make me move to burn fluid resuscitations, and which is fluid crystalloid only used in the burn area, Hartmann's solution or ringer lactate. After you calculate the total burn surface area, the rule of 9, head 9% and back is 18, chest are 18%, right arm, left arm, each one 9%, and the lower limb, each one containing 18%. After you calculate the total burn surface area, you have another rule in the Parkland formula to calculate the fluid needed for resuscitation. The total in this equation, using this equation, total fluid requirement in 24 hours is 4 milli by total percent multiplied by total burn surface area multiplied by body weight in kilogram. 50% of the total is given in first 8 hours, which is very important, and the other 50% is given in next 16 hours. This is the end of the most concept of you need to know about fluid in MRCS. We'll talk now about electrolyte, and we'll start by potassium, the most important electrolyte in the MRCS. It's the main intracellular cation, and it's at the level 3.5 to 5% millimole per liter. Saliva contains the higher potassium concentration than other secretion of the body. We'll talk about causes, we'll talk about symptoms, we'll talk about treatment of either hyperkalemia or hypokalemia. Start by causes. The hyperkalemia, which is mean increasing of potassium level in the blood, have three main causes, and other hypokalemia have three causes. And before talking about causes, there is the key point of the potassium regulation inside the body, the acid-base balance and internal potassium exchange. In the acidosis, the body trying to get rid of hydrogen, so they exchange the hydrogen to enter inside the cell, and the potassium is out in the blood, causing hyperkalemia. Otherwise, in the alkalosis, the body needs more hydrogen from the cells, so it exchange the potassium to go out inside the cells, and the hydrogen out to correct the alkalosis in the blood, causing hypokalemia. This concept you should know when you think about causes and when you think about treatment of hypo or hyperkalemia. We'll return to the causes. There's three causes that cause hyper or hypokalemia. The first one is increased dietary intake, may cause hyperkalemia, and in decreased intake, incorrect intravenous fluid may cause hypokalemia. The redistribution from intracellular fluid to extracellular fluid, like in pH changes, metabolic acidosis, like we talked about before, or in cellular damage, that the cell is damaged and release its content of the potassium. The crush injury, like in crush injury or burn or hemolysis. In the hypokalemia, the metabolic alkalosis causing hypokalemia. The last mechanism that causes hyperkalemia is decreased excretion. The amount of potassium that the body excrete will be decreased. The body can't get rid of potassium, like in renal failure, or using potassium sparing diuretics, or in adrenal disease like Addison disease, or drugs like angiotensin converting enzyme inhibitors. On the other hand, the hypokalemia is caused by increase of loss of potassium, and loss of potassium it's mean the loss of potassium fluids, which is GIT loss or diarrhea, or losing diuretics that not sparing the potassium, or renal loss in some parts of the renal failure stage, or Conn's syndrome. So hyperkalemia or hypokalemia, the causes is very easy to know if you know the exact mechanism of the three causes of the hypo or hyperkalemia. That makes us to go to for clinically what symptoms of the hyperkalemia and which symptoms of hypokalemia, and the ECG changes is very important as well. The hyperkalemia The patient with hyperkalemia will have muscle twitches and cramps and paresthesia, irritability and anxiety, dysarthria, abdominal cramping and diarrhea. On the other hand, in the hypokalemia, we will have alkalosis, shallow respiration, irritability, confusion and weakness. And intestinal motility will be increased with nausea and vomiting. The other things which is more important than symptoms, which is ECG. The ECG changes in the hyperkalemia or hypokalemia, it's more important than symptoms. In the hyperkalemia, the heart will have a characteristic ECG, which is mainly prolonged PR interval, widened QRS complex, depressed ST segment, and tall peaked T waves. The two most important is widened QRS and tall peaked T waves, the two characteristic for hyperkalemia. On the other hand, in hypokalemia, you have a ST depression, shallow T wave, and prominent U wave. The prominent U wave is important in the hypokalemia. So, in the potassium, hypokalemia and hyperkalemia, it's important to know the ECG changes for each one. That takes us to the treatment of the hyper or hypokalemia. The hyperkalemia, there is a mnemonics with big C and S. Big C and S. Big BI for sodium bicarbonate, which stimulates kidney to excrete more potassium. We need to get rid of potassium either in renal, in the urine, or in the cells. So this is the concept of the treatment in hyperkalemia, which is an urgent situation. The big C and S, the first one is BI, the sodium bicarbonate, stimulate kidney to excrete more potassium in urine. Also the G for glucose insulin infusion, which stimulates cellular uptake of potassium back to the cells. The C for calcium gluconate, which is the most important and the first priority to stabilize the heart. 10 ml of 10 calcium gluconate injections for these patients. The S, the last one, is salbutamol nebulizers, which activate sodium potassium pump, which in turn more uptake of cells of potassium. So in the hyperkalemia, big C and S. In the hypokalemia, if the potassium, either the potassium level is less than 2.5 millimole per liters, which is an urgent situation, we have need for rapid intravenous potassium infusion with ECG monitoring. But if we have a mild hypokalemia, which is mean the level of potassium is more than 2.5 milliliters per liters, the potassium level can be improved by increasing potassium dietary intake. This is the treatment of the hyper and hypokalemia. This leads us to finish the potassium and going for the last segment of our lecture today about fluid and electrolyte, which is the sodium. The most important part of the sodium in the MRCS, it's only the causes, it's the most important one. You may read about treatment and causes and manifestations of the sodium in the MRCS, but it's just for your knowledge. But the most important one, which is covered by these lectures, which is the causes of the hyponatremia. Hyponatremia, it may be either loss of sodium or excess water causing dilution of the sodium which are already present in the blood. The loss of sodium may be through renal loss or extrarenal loss. The extrarenal loss means GIT loss, as in vomiting and diarrhea, or in burns. The loss extrarenal of the sodium. On the other hand, in the renal loss, patient often hypovolemic, and we use diuretic, especially thiazides, and in diuretic stage of renal failure or Addison disease. The loss of sodium in the urine will be more and causing hyponatremia. On the other hand, the hyponatremia can cause by excess water. Like in polydipsia, the patient drink water in amount that cause dilution of the blood in the vessels, overtransfusion of crystalloid, syndrome of inappropriate secretion of ADH, antidiuretic hormones, heart failure, or hepatic cirrhosis or nephrotic syndrome. All these causes causing excess water in the blood volume and causing dilution of the sodium content. You can follow us at mrcscloud.com or facebook.com/mrcscloud or YouTube channel. Thank you.